Hi everyone, this is the last recorded lecture for this series, or for this class. Next week there is, instead of having a lesson in the textbook, there are two continuing education classes to take on depression and anxiety. So this course, this lesson is eating disorders, and it's chapter 57 in the 5th edition of Darby and Walsh. And these are the objectives for this section here. So the APA published the Diagnostic and Statistical Manual of Mental Disorders. And with that, the American Psychiatric Association is the APA. And with that, they classified eating disorders as a mental disorder. So we want to be aware of and sensitive to the fact that any form of mental illness may have negative connotations. We live in a time when we still have not fully gotten beyond that stigma that if you have a mental illness, there's just something fundamentally wrong with you. We don't think that about somebody who has diabetes or pancreatitis or, any other kind of illness, but mental illness still holds quite a stigma. So we have to be very sensitive to that and aware of that, even more so in the way that people who oftentimes suffer from anorexia or bulimia may tend to be adolescent boys and girls who tend to be so much more sensitive and need so much more care and understanding. And the minute they think there's something mentally wrong with them, it might just, throw fuel on the fire. What are the current theories regarding the causes of eating disorders? Well, current theories regarding anorexia and bulimia suggest a complex interrelationship among both biological, genetic, and psychodevelopmental, neurochemical, and social cultural components. So it's not just like, I hate my body, I'm gonna not eat. It's far, far more complex than that. An interprofessional, collaborative, patient-centered approach to care is recognized as being important to patient treatment and recovery. Box 57.1, for those of you who have the 5th edition, there's some good information there. So the eating disorders are characterized as anorexia nervosa, bulimia nervosa, and binge eating disorder. And then eating disorders not otherwise specified could include compulsive overeating, compulsive overexercising, night eating syndrome, and then sleep eating disorder. So eating disorders, dental hygienists, we're ethically responsible to help patients access health care. So if we notice these symptoms and things that lead us to be suspicious or think something might be happening with an eating disorder, it's really our ethical responsibility to do our best to help patients find the right help. Care is enhanced by patient-centered collaborative practice approach, and dental hygienists may be the first health professional to identify an oral and physical manifestation characteristic of an eating disorder that might easily go overlooked by a physician. 3 diagnostic characteristics of anorexia nervosa. There's restriction of eating relative to required nutritional needs, resulting in significantly low body weight, irrational fear of being fat or of gaining weight, lack of recognition of health challenges due to the restriction and thought processes. And then there's 2 specific types. There's the restricting type, and then there's the binge eating and purging type. So there's some good tables in the textbook 57.1, 57.2, and box 57.4. Those depict some good information there. Anorexia nervosa is seen during adolescence and young adulthood, although it can appear in adulthood as well, but more often in adolescence. It has a prevalence of approximately a 10-to-1 female to male ratio. So far, far, far more prevalent in females, but it can exist in males, and a crude mortality rate of about 5% per decade. So, I don't know whether you'd think that that's high number or not. It seems still like anybody who dies from it, it's horribly tragic. Psychologic, emotional, and mental health challenges that are comorbid with eating disorders include major depression, anxiety disorders, substance abuse, self-injurious behavior, and restricted affects and capacity for insight. Just not being able to see the circumstances for what they really are. With bulimia nervosa, characterized by repeated binge eating, there's two specific types, the purging type and then the non-purging type. 4 diagnostic criteria: eating significantly more food than what would be considered a normal amount, doing so without control, just overeating, purging behaviors to offset the binge, so wanting to throw it all up to offset eating so much. Binging and purging behaviors occur approximately once a week for a minimum of 3 months. So if it goes on for that period of time, then we're into some kind of a habitual characteristic of it. Individuals' sense of worth is dependent on their body weight and shape. If an individual engages in self-induced vomiting or the misuse of laxatives, diuretics, enemas, the condition is called the purging type. So anything that is getting rid of stuff from their body. If he or she uses another type of inappropriate compensatory behavior to prevent weight gain, excessive exercising, for example, or excessive fasting, but does not regularly vomit or misuse laxatives, then the condition is considered non-purging. Bulimia nervosa is more common than anorexia nervosa. And the onset generally occurs during the late teenage years and young adulthood, but it can be seen in adulthood as well. And estimated rates 1 to 1.5% of the population, and prevalence is higher among women than men. And then the crude mortality rate is about 2% per decade. And the course and outcome of bulimia nervosa are variable, but the condition tends to be chronic and relapses occur. So professional help may be sought by the person as a result of the discomfort of their dentition, especially from the chronic throwing up. So the dental hygienist may be the first health professional to help the patient begin his or her journey into recovery. So their teeth may be sensitive. They may start to notice an appearance that they don't like. And so that's why they may come see a dentist or a hygienist first before a doctor or a physician is aware of the condition. Health effects of anorexia nervosa and bulimia nervosa. Treatment is challenging and the recovery period is super lengthy. I've watched some really interesting videos of individuals with anorexia, and to get them to start eating a normal amount is an amazing uphill battle. I'll try and find a video and put it in this week for if you have time to watch some of the stories. It's just an amazing uphill battle to get them to eat small amounts of food. Dental hygienists must be vigilant to support recovery. Dental hygienists must always remain empathetic. As in all things, empathy is so important. So the effects of anorexia nervosa and bulimia nervosa on the psychosocial and psychological well-being of an individual are really significant. From a patient-centered approach, anorexia nervosa can be thought of as an eclipsing of the person's thinking by the eating disorder. In other words, the person's identity is centered on the eating disorder. It has so much to do with control and feeling just out of control if they've eaten something, if more food than they think they should have goes into their body, just a crazy feeling of out of control. And so controlling the amount of food going into their body has so much to do with their identity. Psychosocial Dimension, Anorexia Nervosa, control of food and perfectionist behavior, bringing feeling of competence and control of their lives. Bulimia Nervosa, behavior becomes self-reinforcing. Dental hygienists should understand that a key role is to help patient with human needs for conceptualization and problem solving. Impaired psychologic development and associated distortion of attitudes in the patient with an eating disorder provide the foundation for continued dysfunction and a progression of the disorder. So the more they sort of settle into this distorted attitude, this distorted thinking, it just provides that foundation and it just feeds it, and it makes it just, they just reinforce that behavior onto themselves. Psychologic responses. So for anorexia nervosa, impaired individuals' overall functioning and health, hormonal abnormalities, and then vital statistics. For bulimia nervosa, dehydration, electrolyte imbalance, gastric dilation, esophagitis. I'm trying to think how I should have said that different. Just inflammation of the esophagus is basically, or tears in the esophageal from the continuous vomiting. If a person is constipated, he or she may be dehydrated. Dehydration is evidence in reduced salivary flow, and then quality and effects of oral health as well. So other general physical findings, common physical findings for patients with anorexia nervosa are lanugo, that it's a fine downy hair found on lower half of the face and the upper body. I always find this kind of weird because I have a lot of fine blonde facial hair, like so much it drives me crazy. And so I always want to remove it. So I feel like that would be a little bit hard to, I have never seen that in person. I've just, seen facial hair on people, but many people have it. So I think it's interesting to look that up and to look up pictures of that, and to try and see how that might be different. And then somebody who is anorexic might have a constant feeling of being cold. Common physical findings for patients with bulimia nervosa is calloused knuckles from scraping their knuckles over their teeth over and over again in trying to induce vomiting. And then oral lesions and bruising. Sometimes they don't use their finger, they may use a device, something, some kind of, I don't know, the end of like a wooden spoon or something to gag themselves to induce vomiting, and that could cause palatal bruising. The dental hygienist needs to be aware of these presentations and gently engage in the patient in a discussion about what could possibly be causing them. So some things that you might notice as an oral health healthcare worker, oral health implications. You may see the parotid gland could potentially look enlarged, diminished taste acuity if a patient is not tasting things from the chronic vomiting, dehydration and xerostomia, stickiness to their mucosa, perimyolysis or enamel erosion, intraoral trauma from, various things, maybe shoving something in the back of their throat. Again, maybe they knocked something or causing ulcerations or bruising, increased risk of dental caries from xerostomia, periodontal disease, dental hypersensitivity, again, intraoral trauma, that's repeated, other comorbid disorders, oral side effects of medications, oral health systemic issues. So a little bit more on that. The patient with an eating disorder may exhibit one or more of these manifestations, yet some may exhibit none of them at all. So it can be very silent disorder for sure. Although it will not be obvious from the intraoral examination, diminished taste acuity has been reported by patients with eating disorders. So, that's something, if you see something, you could also ask them about their taste. How have they lost the ability to taste? So ghrelin is a hormone that's produced in the stomach and sends signals to the brain to indicate hunger. So that is one thing that they may have hormonal changes. So that may be suppressed perhaps. Perimyolysis, also spelled perimyolysis, or the enamel erosion, is the most common dental finding in patients who orally purge. So we also can see erosion though in patients who have GERD and acid reflux. So there are other reasons. So that's why gentle questioning is important and not just a full-on like, oh my goodness, do you throw up all the time? Because it could be, for one, it would be very sensitive topic if they were bulimic. And for two, they could not be bulimic. They could simply have GERD. So we have to be aware of all these differences and have very cautious questioning. Decreased salivary flow along the distributed dietary patterns may predispose the patient to an increase in dental caries rate. So since they're going to have potentially less salivary flow, and then depending on what they do eat, they may be predisposed to caries. Eating disorders place the patients at risk for periodontal disease due to the number of factors, including they're nutritionally deprived, so they're missing some major nutrients that help to keep everything healthy. Malnutrition inhibits the body's ability to properly maintain itself. Prescribed medications or other drugs may contribute to xerostomia. So now we're kind of layering on these issues. Depression, often seen with eating disorders, may result in apathy toward oral hygiene. So they just aren't really valuing perhaps their oral hygiene. Intraoral trauma may be evident in patients who orally purge or regurgitate the stomach contents. So the process of care for dental hygienists. Dental hygiene sequence the SCOFF questionnaire, and that is, I believe that is in your text, but I'm going to pause this and pull it up. Hold on. Okay, so the SCOFF questionnaire, I think this is in your textbook, but I don't have it open in front of me. But the SCOFF questionnaire asks, do you make yourself sick because you feel uncomfortably full? Do you worry that you have lost control over how much you eat? Have you recently lost more than one, well, they say 1 stone, but that's 14 pounds, in a 3-month period? Do you believe yourself to be fat when others say you are too thin? Would you say that food dominates your life? So the SCOFF is sick, control, 1, fat, and food. That's what the letters stand for. And that, I feel like we could certainly pose that question to our patients, and they may or may not answer honestly. They may or may not feel comfortable answering it. But just the fact that somebody cared enough to ask them that and somebody noticed may be like the very first start, on their road to wondering, what am I doing, or I need help. And so then I feel like as hygienists, something that always comes to my mind anyways is, but I'm not a psychiatrist. I'm not an expert in mental illness. How will I help this individual? But it's knowing how to recognize certain things and then bringing the care, being like somebody that is like a bridge to another care provider that could potentially help them or refer them to who they need for medical or psychological therapy. So that's really where our role lies, because we are the first eyes sometimes that sees certain conditions. And so that's where that role comes into play. So, me just scroll back up to the top here. So for individuals with eating disorders who have not been medically diagnosed, the dental hygienist may be the health professional who identifies the need for referral to the healthcare team. The assessment of all dental hygiene patients involves data collection regarding the patient's comprehensive health history, intraoral, extraoral status, and physical status. The secrecy and shame associated with eating disorders can cause patients to avoid dental care until oral manifestations appear. So once something does appear and it forces them in and then it's recognized, that really can be that tipping point. Dental hygiene diagnosis can be accomplished using objective and subjective findings to determine deficits in the human needs related to dental hygiene care. Continual evaluation of the patient's oral health status and psychological therapy is one of the most critical functions of the dental hygienist when working with a patient with an eating disorder. The dental hygienist is well positioned to educate the patient about oral health issues such as perimyelitis or that erosion of their teeth, how that never comes back, what they're doing is permanent damage, so helping them understand that, the effect of malnutrition, of poor diet on oral health, oral self-care, and pain management during and after periodontal debridement and instrumentation. So dental hygiene human needs care plan for a patient with bulimia nervosa. Record the human needs deficit and set measurable dental hygiene goals. We want them to be free from pain. We want them to have a sound dentition, responsibility of oral health, and then wholesome facial image. And you can refer more to table 57.6 in the textbook for more information there. Implementation. So phase 1, referral of a patient to medical or psychological treatment. So if you get to the point where a patient confides in you and admits to having a problem, the biggest thing to do obviously is refer to somebody with more expertise. Phase 2, the roles and responsibility of the dental team as part of the patient's interprofessional collaborative healthcare team. So your role is to help them understand and maintain oral health, management and support of oral health care during and after eating disorder treatment. So helping them to stabilize and, whatever those next phases are, if it's restorative work, once the harmful act is come to an end, and then hopefully some kind of maybe crowns or restorative procedures can be done. Effective diet on the oral health, oral self-care, and then pain management. So few patients openly admit having an eating disorder when they're questioned about it, and many have become quite accomplished at denial and can maintain that position in the dental environment. So don't be surprised if it doesn't really go anywhere. Individuals with eating disorders commonly react to initial discussion with various emotions. Two common responses are denial, accompanied by tears, and outright anger. The dental hygienist must thoroughly document discussions and decisions regarding referral for evaluation in the patient's permanent dental record. And then professional collaboration between oral health care team and the eating disorder team permits the oral health care team to have a better understanding of a patient's specific psychological issue and increases the success rate of all dental hygiene and dental interventions. Available literature about oral health and eating disorders is limited to case and case control reports, literature reviews, practice experiences, and descriptive studies. So really, to me, that tells me that every situation is kind of different, and if we have a patient that we're allowed to go on this journey with, we'll probably learn a lot. And it's certainly you're not going to have a lot of patients, but if you are able to have a patient that you identify this and you help them and you're sort of member of that team to help them in their recovery, that would be a huge learning opportunity. Education for patients with perimyelitis or the erosion is aimed at eliminating pain and maintaining and fortifying existing tooth structure. So wanting to stop the process of the erosion and then to fortify the existing tooth structure. Evaluation. So the objective of the evaluation Baseline findings, accurate measurements are used to monitor the oral impact on plaque biofilm accumulation, their periodontal status, their dental caries status, their erosion status, their salivary flow status, and the quality of their saliva, their hypersensitivity, where they have it, how badly is it controlled, and oral tissue findings. How is their tissue looking? Are they finding lesions and oral trauma? And then the subjective involves the use of awareness and verbal acknowledgement. So on occasion, objectives and subjective evaluations conflict with each other. The dental hygienist should consider the nature of eating disorders and the questions whether the patient's statement is a reflection of the thinking associated with the eating disorder. Is the patient in a state of denial, or is he or she hiding true information? This is where the comparison of objective baseline findings is invaluable for the documenting of change. So we might see all this proof, this just hard proof in their mouth, and then when we talk to them, they deny everything. So, but what we can do is we can document, we can assess and evaluate. Continue evaluation of the patient's oral health status and the status of psychological therapy is one of the most critical functions of the dental hygienist when managing the individual with an eating disorder. So our interprofessional collaboration and our patient-centered care. Informed consent, collaboration enhances the quality of care. An interprofessional healthcare plan for a person with an eating disorder may include the following, and you guys can read through that. But interprofessional patient-centered collaboration is of great value to understanding what dental interventions may be of benefit to a recovery and which ones may inhibit it. So explain the need to coordinate non-emergency restorative and prosthetic dental care with psychological therapy. So patients may be in an inpatient, they may be in a facility for a while they're in recovery, maybe an outpatient, maybe a day program, or they could be hospitalized depending on how sick. And then there's psychotherapy, nutritional treatment planning, physical education, therapist, possible psychopharmacologic treatments, and prevention of oral health risks. So all of that may be included. And if we are a part of the interprofessional team, we can put our knowledge base into that plan, that healthcare plan. And these are some resources for further information for eating disorders. Valuable information about eating disorders is available online from credible organizations and associations. Each association has resource listings for personal and professional help that the dental hygienist can share with patients.